a lo que sea ya como. Good morning and hello everyone. I'm Dr. Ricardo Sanchez, pediatric resident, and I'm here with my friend and colleague, Dr. Emanuel Troncoso. We are both physicians from Barranquilla-Colombia, the place where we practice medicine, and we are really happy to be here with all of you, sharing in our experience with this rare pathology, rare disease. Really hard to make a diagnosis of it. And so we are really thankful with SciTech for inviting us to be part of this international conference. Um, it's a really interesting case since it's not frequent to see it, since it's hard to make the diagnosis, even though the literature says that it's practically a pediatric disease. It's not frequent to see it in our daily basis. So it's really interesting to see how it develops. So the idea is trying to present the case, and after that, making like a brief summary of how to oh, a summary of how to evaluate patients with this disease. So first, we like to go through the case. Then we make an approach of the differential diagnosis. In this case, necrotizing encephalitis. Then we will talk about keys for the diagnosis, and at the end, what does the evidence say about the treatment? So to begin with, we have to say the personal data. Obviously, we are skipping the name for terms of privacy, but we have our patient. He's an 8-year-old male. He was born in Barranquilla, but he currently lives in Sabana Larga, which is like it's a town nearby, close to Barranquilla. He was actually transferred or referred from the hospital of Sabana Larga to our hospital in Barranquilla. Why? What did his mother said to us? That he had a 3-day history of fever. He was initially treated with acetaminophen and with oral rehydration solutions, but it wasn't getting better. He wasn't getting any improvement, so she decided to take him to the first level of care in Sabana Larga, where they performed some blood tests without any pathological findings. So they decided to discharge him, send him home with antipyretics, but he wasn't getting any better. Actually, he was getting worse. By the 5th day of the of symptoms, he started with liquid stools and he was turning hypoactive, agitated, hyperexic. So his mother started getting more worried about him. And by the end or by the night of the 5th day, he presented a clonic movement in the left upper limb associated with fixed gaze, hypersalivation, and trismus, with a duration of approximately 3 minutes and a post-ictal period of 10 minutes, with a repetition of that seizure episodes in 2 occasions. That's why his mom took him to the hospital of Sabana Larga, and they transferred him to our hospital in Barranquilla to seek or looking for specialized treatment, specialized consult for the pediatric team and the neuropediatric team. By the time he got to our hospital, he was referring, oh well, his mom was referring nauseous with some occasional wet cough associated with liquid stools. Apparently, no more crisis. He was, in terms of medical history, he was a healthy boy. Actually, no hospitalizations records. He was born full term at 38 weeks, right birth weight, the right height, uh, all of his pregnancy, the pregnancy was controlled. He had completed immunizations for his age. He only referred umbilical hernia at his age of 6. Physical exam at the moment of the admission in the emergency room. He had a normal heart rate, normal respiratory rate, but he was feverish. He had a temperature of 38 degrees, which is uh, which is fever for us here in Colombia. Normal or blood pressure at the normal rate, normal oxygen saturation at 99%, and the right height and right weight for his age. What did we find at the physical examination? Well, it was really noticeable that the patient was feverish, but he was also disconnected from the environment. He was aphasic with a good respiratory pattern, but he was, as I said, aphasic, disoriented with Glasgow 13/15, ataxic gait, and a loss of support posture. Therefore, those were our initial signs of alarm. So the first diagnosis impressions were fever or acute fever, the seizures, neurological deficit, and acute diarrheal illness and aphasia. So the first labs or orders, or so yeah, the first labs were blood tests that actually was normal, nothing out of the normal range, negative uh, acute inflammatory reactants. The arterial blood gases were actually normal. Kidney function was under normal range. A little bit of hyponatremia, but nothing that worried us. The chest rate was normal, but the skull CT scan show bilateral hypothalamic hypodensity, probably of infectious origin and less likely to be of vascular origin. So, given all those findings in the CT scan and all of the findings in the physical examination, they decided to send him to the IC to the pediatric ICU, start him with oxygen in case of another seizure, paracetamol for control the fever, hydrate him with intravenous fluids with normal saline, phenytoin at a doses of impregnation of 10 milligrams per kilo, and then phenytoin at a doses of 5 milligrams per kilo every 8 hours, and midazolam in case of presenting a new seizure. They ordered some tests, including glucose, and they ordered a lumbar puncture with cerebral spinal fluid, cytochemistry, and culture. Um, at the day 5 of uh, hospitalization, the patient was considered to have probable encephalitis. The etiology of which it was still yet to determine. They performed the lumbar puncture and start the patient in acyclovir treatment under the impressions of seizures, neuroinfections to rule out viral versus autoimmune encephalitis and risk of neurological deterioration. They keep the phenytoin and paracetamol and midazolam in case of seizures. Now, the neuropediatrics team reached the patient for his first evaluation, and they consider him a previously healthy patient that had a fever 3 days prior to admission, which gradually increased with altered consciousness and a tendency towards drowsiness, limited spontaneous movement, bradypsychia, bradylalia, and the patients had an encephalopathy under evaluation, and neuroinfection was to rule out as a first step. So they also ordered the CSF film array for common germ culture and requested an encephalogram. And also they requested a brain MRI with and without contrast. These were the results for the lumbar puncture. Actually, they were normal, so they were negative for any signs of neuroinfection. So by the end of that day, the 5th day of evaluation, the cytochemical report was only reported a mild protein concentration. And the neuropediatric service considered the patient to be, or probably, autoimmune encephalitis, and that's why they started him in methylprednisolone. And also, they requested immunological paraclinical tests. These were the results. So negative for dengue. The CSF culture was negative at the 48 hours, but the main findings were in the EEG, or electroencephalogram, that was abnormal due to the inadequate organization of background rhythms expected for his age, and the CT scan showed the basically focal and symmetrical hypodensity in the bilateral thalamic region with no associated mass effect. These are the images. Okay. So by the day number 7, the patient started kind of improving with few spontaneous movement, still with bradycekia, with bradylalia, still with treated with phenytoin without any new crisis. Uh, Neurology service considered the patient to be suffering from encephalitis of probable viral or autoimmune origin, and continued the management with the intravenous corticosteroid pulses for 5 days, and also with the aciclovir. By the day number 8, the neurological level of the patient is improving. He seems more active. He's interacting well with the examiners. His Glasgow is 14 over 15, no new seizures, and continues with being treated with phenytoin. By the day 9, neurologically more active, good interaction with the examiner. Glasgow has improved without any new seizures, uh, but still pending the report of the MRI. He, by this day, has already completed corticosteroid pulses. By the day number 10, without any further seizures, he completed the intravenous corticoid pulses, and pediatric neurology is suspecting autoimmune encephalitis. But then we get the report of the brain MRI that says the following: highly suggestive hypoxia ischemic lesions involving the thalami, inferior colliculi, and vermis bilaterally and symmetrically in the midline. Subtle changes of diffuse cortical cerebral atrophy for the patient's age. And that's why they consider uh, the diagnosis of acute necrotizing encephalitis. And they then prescribe human immunoglobulin, 9 ampules of 5 grams, to contain a total of 24 grams of the immunoglobulin, infused continuously for 8 hours. Under the diagnosis impression of acute necrotizing encephalitis. The results of the other labs that they ordered that were actually normal or negative for infections. Thyroid profile under normal ranges, just as liver function was normal. And by the day 13 of hospitalization, the patient started getting better, and due to his favorable progress, they decided to transfer him to the general pediatric ward to keep the treatment. They indicated physical therapy evaluation to initiate the rehab. Since his stay in the ICU could lead to post-traumatic stress disorder. And they also changed the methylprednisolone. They indicated now uh, prednisolone, okay, for 5 days. Normal labs, as I said, the rest of the labs were normal. And by the day 15, they considered the patient with acute necrotizing encephalitis directly affecting the brain system. Significant improvement with the immunosuppressive therapy persists with motor neurological sequelae, and cognitive, visual, and auditory sequelae are yet to be determined. Currently receiving maintenance corticosteroid at 1 milligram per kilo day orally. Given the patient improvement, the neurological team considered discharge to the Department of Outpatients. So they discharged him, and currently he has yet some impairments, or especially uh, in terms of motor neurological sequelae, but he's getting better and better.
Okay, so after my partner made the explanation about the clinical case in a wonderful way, I'm going to talk about the approach of necrotizing encephalitis. We knew, or he described about the symptoms, the process of diagnosis, but the first thing that we have to know is the definition. The acute necrotic encephalitis is an acute onset cerebral dysfunction syndrome consisting of altered consciousness with or without behavioral disorders, or with epilepsy or other focal disturbance. The first case was described by Misuguchi in 1995, and this is a rapidly progressive encephalopathy that is triggered by an exaggerated cytokines response to certain infections. Those infections are actually more viral than bacterial. Also, we have to know, or we have to talk about the epidemiology. Is an incidence is unknown because the cases are really hard to diagnose and currently, and also we have different presentations of the symptoms. We have the AIN isolate and we have the AIN with an hereditary dispositions. Those dispositions are identified in certain studies that associate the RAMBP2 gene mutations with an familiar disease, and those cases have been reported in Europe and United States. So, in this article is the main article that makes the relation with the gene and RAMBP2 with the acute necrotic encephalitis. This article made a follow-up of 13 patients and also there's 13 families. They, after making the genetic panel, they make the, we may say that the discovery or maybe the way that they identify the RAMBP2 protein. This protein is also located in the cytoplasmatic surface of the nuclear pore, and this protein has an important role in the cellular cycle, especially in those cells that are the neurons. And this protein is related with the mitochondria. So this is the first study that related a gene with this pathology. So We now know the definition, we know the probably and the pathology, but also we need to know the etiology. What is the trigger of this disease? The main trigger are also the virus disease or the viral disease. Those viruses are also the influenza virus, the human herpes virus, the rotavirus, and respiratory syncytial virus. This virus also the main stage um, is for the influenza virus, which has also the 27% of total cases. So this is the main virus that we have to rule out in those patients with posterior neurological disease. Okay, so the physiopathology are some certain theories. Those theories are also uncertain. Why? Because we don't have the right conclusion about what is the way that the pathology um, is attacking the body. So the physiopathology also says that there is a cytokine storm that is caused by an exaggerated immune response. This response is led by certain cytokines or certain interleukins that are interleukin 6, 10, and 15, and also the tumoral necrosis factor. This tumoral necrosis factor is also really harm to the cerebral, to the central nervous system, endothelium, and also the interleukin 6 is neurotoxical in high concentrations, which is what happens in this pathology. We have to know that there are some certain clinical manifestations, and those patients that develop an AIN or acute necrotic encephalopathy also has certain prodrome. This prodrome is characterized by cough, vomiting, diarrhea, and skin erythema. The acute encephalopathy is the main stage of the pathology and also is characterized by seizures, alteration of consciousness, and focal deficits. And the recuperation is also the best part. We can say that not all the patients have the privilege of having, because this pathology have high mortality rates. And the recuperation stage has a neurological sequelae and some other recover completely. Maybe approximately 40% of the cases has um, neurological sequelae, and also 10% of the cases has completely recovery. The acute necrotic encephalopathy has a clinical diagnosis, imaging diagnosis, but also it needs a laboratory diagnosis. The common biochemical abnormality described in acute necrotizing encephalopathy are the metabolic acidosis, also high serum aspartate aminotransferase, and also creatinine kinase elevated. BUN is elevated in those patients because of the kidney damage due to the immune system response, and CSF proteins elevated in 80% of the cases, which wasn't the case in our clinical report. The neuroimage is one, if not the most important way to make the diagnosis. The diagnosis is by MRI, and we can see in this image the A, which is a center of thalamic lesions characterized by hemorrhage and necrosis. In the letter B, we can see peripheral areas characterized by cytotoxic edema. And in the letter C, we can see external areas suggesting vasogenic edema, which is linked to the immune response system. We have the diagnosis criteria. which is proposed by Mizuguchi in 1995. He was the first one to propose this diagnosis criteria, and all the cases have to meet these diagnosis criteria. First, encephalopathy is preceded by a febrile viral illness with a rapid deterioration of the level of consciousness and seizures. Also, there should be ancient cerebrospinal fluid pleocytosis. There should be in the MRI symmetrical multilocal brain lesions, and there should be elevation of serum aminotransferase level, and we have to do an exclusion to other similar disease. There are other criteria diagnosis or other criteria diagnosis that are the Nelson criteria. They are also similar to the Suguchi previous one, and they have the clinical presentation that is an acute encephalopathy 1 to 3 days after a febrile illness, and this require impairment of consciousness made by coma or in other cases seizures. Like in this case, the labs are some variables, but they describe increased serum transaminase, and also in the cerebrospinal fluids, they say that there should be absence of pleocytosis increase in proteins. The MRI show multiple lesions that we described before, but the first and more important are lesions bilateral involve the thalamus, and we have to do an exclusion of other disease. The severity scale also is really important because it's a way that we can stratify those patients that had low, medium, and high risk. How we stratify or classify those patients? By the signs and symptoms, and also by the labs and by the characteristic of the patients, like the age, the shock, the brainstem lesions, the platelets, and also the cerebrospinal fluids. We can classify in low risk to 0 to 1, medium risk to 2 to 4, and also high risk 5 to 9. We know that those patients that has an age less than 1 year and also that has brainstem lesion are some of the higher risk patients and have bad prognosis. The treatment is also a really discussion area because some articles say that methylprednisolone is the best treatment for the AIN and also is really good in our treatment. Immunoglobulins have no evidence of efficacy, but some people use it because it exerts an anti-inflammatory action by suppressing the activation of the immunocompetent cells and also by suppressing the production of inflammatory cytokines. So in this pathology that is a process inflammatory, it should be helpful. And plasmapheresis aims to control the inflammation by removing the inflammatory substance such as cytokines in the blood. And theoretically, it should be really helpful. Some articles say that have good prognosis those patients that went to the treatment by plasmapheresis, but also this should be performed by experienced facilities because the treatment is more invasive. In this article, they make a retrospective study that reviewed the medical records of 26 children with the treatment of methylprednisolone, and they made the conclusion that pulse storage therapy used within 24 hours after the onset of the acute necrotic encephalopathy result in significantly better outcomes. And in this other meta-analysis, we can see that high-dose steroid is better than don't giving the high-dose steroids. There is no better outcome in those patients with immunoglobulins treatment, and we can see a really a really excellent survival in those patients that went under plasmapheresis versus those that weren't that didn't use plasmapheresis or didn't when given the treatment. And the differential diagnosis is really important because there are many pathologies that produce symptoms similar and also affect the brain system and can produce encephalopathy. Between those, we can divide in some clinical point of view and some by neuroimaging. From clinical point of view, we have severe bacterial and viral infection, we have pulmonary hepatitis, we have toxic shock and Ray's syndrome. By the neuroimage, we have multiple encephalopathy like Wernicke, carbon monoxide, poison, and some traumatic injuries. The prognosis of this pathology is really bad because we have an average mortality of 30%, and those patients that didn't die by this disease also has a really, let's say, that not a good prognosis because they also live with serious sequelae, like the 28% of the cases, moderate the 23% of the cases, and also at 12.8 of the cases have male sequelae, and only at 10% of the cases have a complete recovery. So this is a really burden pathology that affected the family and also the patient. So there is always new knowledge waiting, so keep calm and investigate because new things will be in the future, and also the truth of today will be the lie of tomorrow. And we have to keep searching for more knowledge. Thanks to SciTech for inviting us to this conference.
Thank you. We hope you all liked it. And well, thanks.